Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. A recognized expert in periodontics, CBCT imaging, dental implant surgery, and tissue engineering, Dr. George Mandelaris was appointed by the American Academy of Perio in 2015 to co-chair the Best Evidence Consensus Workshop on the use of CBCT imaging in periodontics, as well as co-authoring the Academy guidelines. He maintains a private practice and is the director of the Seattle Study Club in Oak Brook, Illinois.
Hi, I'm George Mandelaris. I'm a periodontist in private practice in Oak Brook Terrace and Park Ridge, Illinois, and I'd like to talk to you today about surgically facilitated orthodontic therapy. The lecture goals that we're going to talk about are the human condition, or what we'll call, what's the human problem? We're going to classify dental alveolar and alveoloskeletal bone phenotypes, reevaluate outcome goals from an orthodontic, periodontic, and restorative standpoint, and then I'd like to show you a case involving corticotomy surgery and the regional accelerator phenomena, as well as define what those are. So let's start with what SFOT is, or surgically facilitated orthodontic therapy, which is really a form of tissue engineering of the dental alveolar and the alveoloskeletal bone phenotypes. The reason that we do it is not to move teeth quickly, although that is a benefit. We do it to put teeth in the right position for facial aesthetics, to transform the phenotype in order to make number one happen, in order to improve the long-term orthodontic stability and reduce the incidence of orthodontic relapse, as well as to optimize anterior protected articulation parameters. And perhaps most importantly, with what we know today with airway, is to consider airway dimensions and not make the box smaller with retractive orthodontics, but rather make the box bigger with non-retractive orthodontia. These are the 5 reasons that we do SFOT in our practice today. So it's all about space appropriation. And some of the structures that we've typically modified in complex cases are the coronal morphology of the tooth that may be worn, the root position, which we generally have always conceded that we can't take outside the orthodontic envelope, and we've really never done anything with the dental alveolar bone, which is perhaps the most plastic structure in the body. Today, what we're saying is a paradigm shift is upon us. We're altering the dental alveolar bone to put the roots in the right position for facial aesthetics and function, and then trying to do the most minimally invasive dentistry to restore the lost tooth form. Our lecture goals are going to be the following, and we're going to start with the human problem, or let's say the human condition. Anthropologically, there's been a condition known as klinorhynchi, and essentially what's happened over the thousands and thousands of years has been this phenomena where the brain has enlarged and it has essentially folded the face back under. So you can see very clearly on the slide to the left in the monkey that the brain case is somewhat, has a rather straight slope in terms of the cranium, and there are 2 distinct compartments, the pharyngeal compartment and the oral compartment. As we've evolved over time and as the brain has gotten larger, the face is folded back in, which has essentially impinged the oral cavity onto the pharyngeal component. So there's been a change in the angulation of the basic cranium and because of the enlargement of the brain, and that has essentially folded the face backwards. So there's been essentially a rotation of the muzzle with an increase in the brain size, as this slide depicts, from the crocodile, which is located in 1, to the dog in 2, and then the human in 3. You can see a rotation of the muzzle as we've gotten smarter. So there's been a recession of the face with an increased size of the brain case, as you see from this picture here. During growth, there are known resorptive fields of the craniofacial skeleton. These are depicted here in red. And then after growth, we have muscle pressure, which exerts a continuous and a slow resorptive effect indefinitely. During growth of the mandible, you see this process known as modeling, where we have active bone resorption and deposition, making room for the molars, or the so-called cortical drift. And in the maxilla, the face is essentially growing out through the spheno-occipital and spheno-ethmoidal synchondroses. As I mentioned earlier, once growth ceases, we have a continuous slow resorptive effect of muscle pressure indefinitely. And this imposes changes on the bone morphology that we oftentimes see during surgical intervention. This is a landmark study, in my opinion, that was published in the International Journal of Periodontics and Restorative Dentistry by Dr. Buser and Belzer's group in Switzerland. And essentially what they did is they looked at 500 patients using cone beam CT scan to evaluate what's the facial bone thickness of Caucasian patients in their practice. They considered 2 points, MP1 and MP2. MP1 being 4 millimeters apical to the CEJ, and MP2 essentially being at the mid-root position. The bottom line of this study really underscores the human condition and the difficulty that we have in complex interdisciplinary therapy, which requires implant site development or orthodontic tooth movement that has to occur outside the known bone envelopes. And that is 90% of patients have less than 1 millimeter of facial bone. And that's the difficulty of moving teeth sometimes beyond known limits, or where they perhaps really need to go from a restorative standpoint, because we just don't have the regional anatomy physiologically to make that happen, and alveolar bone really doesn't bend. So is that a problem? Well, typically the lack of facial bone isn't so much of a problem because we're not losing teeth as a result of it, but it can have significant consequences restoratively, orthodontically, or surgically when we intervene. We know that tooth movement, as you move a tooth, there's a compression and a deposition side, or compression and tension side, and no matter what type of bracket that you're using, that's not going to change the normal physiology of known tooth movement. And we end up with a thinning of facial bone. This picture here demonstrates the complex milieu and the highly vascular region of the periodontal organ system, rich in blood vessels in the bone and in the ligament of the tooth. And those blood vessels are bringing with them specific cells known as pericytes, which are almost stem cells a little further down the lineage. So what are some of the consequences of orthodontic expansion? Well, we know this from the 80s, that when we expand teeth, we get a parallel orientation to the fibers of the root, we lose facial bone, we don't necessarily lose attachment, but we end up with no Sharpey's fibers, and we increase the risk for future problems down the road. This study was classic in the sense that as they developed dehiscences through facial tooth movement, they showed that the periosteum has an osteogenic potential, because as they move the teeth back in, the envelope, the bone dehiscences resolved. But with what we know today with Airway, we're generally not trying to make the box smaller, we're generally trying to expand and make the oral cavity volume increased for anterior tongue posturing and perhaps an influence on the airway. This study out of Europe demonstrated the consequences of retractive orthodontia. They looked at 152 patients with class 1 malocclusion that did not exceed 5 millimeters of crowding, and overjet, which was less than or equal to 5 millimeters. Essentially, using cone beam CT scan, what they were able to demonstrate was that in 84% of the cases of mandibular central incisors being retracted, they lost 2 millimeters of bone. This is a problem, and this, I believe, is a call for change. And what about some of the orthopedic procedures that we do in orthognathic surgery? This paper evaluated the periodontal effects of surgically assisted rapid palatal expansion. Given it's only a 6-month study, but in 14 patients who had orthodontic therapy, cone beam CT scan, surgically assisted rapid palatal expansion, then a retention for over a year, and then another cone beam, they demonstrated that while you don't lose attachment, you do thin the buccal alveolar bone by over 55%. Now, we just talked about the fact that 90% of patients have less than 1 millimeter of facial bone, and we're doing procedures today that essentially are making our patients even worse. So we're going to evaluate a classification system that can be used with cone beam CT scan and compartmentalize the facial bone into the crestal component and to the radicular component. The crestal component being from the CEJ to 4 millimeters apical to that, and the radicular component being 4 millimeters apical to the CEJ and beyond the rest of the tooth root. And the first classification is the thick phenotype. So on the surface or clinically, this patient may look something like this, where there's robust gingiva and good attached gingiva, and surgically or anatomically they have thick bone. This patient unfortunately rarely exists. The thin-thick phenotype is a patient where maybe there's a little bit of recession, and when you look at the regional anatomy, there's still bone around the teeth, And this is a patient who would benefit well from perhaps a connective tissue graft. The teeth can still be moved in the limited amount of bone that's there, but this may also be a patient that can benefit from corticotomies and dental alveolar decortication for periodontal regeneration and augmentation, depending on how far the teeth are going to be moved, in addition to the connective tissue grafting. The real problem that we encounter is the thick-thin phenotype. And clinically, this is what the patient will look like. As periodontists, we'll basically evaluate this patient and validate that there isn't any inflammation and periodontal problems. We'll give the okay to the orthodontist. And the only thing that the orthodontist really is banking on is that little crestal bone that's holding those teeth. This is what we call the snake pit. And because it looks good at the crestal level and we're not being mindful of what's going on at the mid-root position, we very quickly turn this patient from a thick-thin phenotype to an extremely vulnerable thin-thin phenotype. On the surface, they'll look something like this. You can see the roots popping through the gum tissues, and anatomically, they look like this. When we lose a tooth with this type of biotype, dental alveolar bone phenotype, this is why implants become so difficult, because now we need to regenerate an exceptional amount of bone in order to have the right peri-implant bone dimensions so that the mucosal health remains stable long term. So this is a quick way of classifying dental alveolar bone phenotypes and assessing risk profile in orthodontic tooth movement for your patients. This was published in the International Journal of Periodontics and Restorative Dentistry, and I hope you'll find this useful. Reevaluating the outcome goals. So now, considering what we know today and what we can accomplish with tissue engineering the dental alveolar bone and alveoloskeletal bone phenotypes, what are our outcome goals from an orthodontic perspective, periodontal perspective, and a restorative perspective? Well, I'd like to think that orthodontists want biologic health, they want long-term stability, they'd hate to see their cases relapse. Certainly, facial aesthetics is where is paramount importance. We'd like to limit extractions. We'd love to have our patients with a beautiful, big, broad smile in the transverse dimension. We also want to have the most optimal AP relationship for airway. We want a good, stable occlusion. From a periodontal standpoint, obviously, we want biologic health. We would love to have a robust phenotype from a dental alveolar bone standpoint. Also, we would like to have a condition where we don't have any mucogingival problems. We want periodontal regeneration where possible. And we want to put the dental gingival complex in the correct position. So we want to correct any altered active or passive eruption patterns that have happened. We also want a stable occlusion. We don't want fremitus or any trauma from occlusion. And from a restorative standpoint, since they're going to be dealing with these patients for the life of the patient, for the long term, they need 1 through 4 in both the perio-ortho categories, and they need space. Why do they need space? They need space to allow for the correct tooth proportions to be restored and to help avoid cyclic fatigue. Good interincisal angle positions around 135 degrees and axial inclinations in the cusp-fossa relationships that will help give stability long term. So, anterior protected articulation. When we place the patient in a fully seated condylar position and unmask a class 2 malocclusion, the problem is that we can't move those teeth forward because generally there isn't enough facial bone and the mandibular incisors to make that happen. But when we do those situations, when we do that type of treatment and we take the patient's teeth out of the dental alveolar bone envelope, we quickly create a situation like this. Today we don't want to do that. We'd like to end up with a situation like this, and this is what surgically facilitated orthodontic therapy can provide. The other alternatives historically have been camouflage orthodontics, to dump the lower incisors forward, platform the upper linguals, or orthognathic surgery. And there is a gray zone that we can now intervene with to help gain better occlusal parameters and outcome goals without having to put the patient through more advanced surgical therapy. Not always, but certainly in many cases that is possible. That is a very real possibility. So let's talk a little bit about the regional acceleratory phenomena and corticotomy surgery. The regional acceleratory phenomena was described in 1981 by Harold Frost. It's essentially a period that lasts in response to injury of 6 to 12 weeks, and it provides an osteopenic event that allows an upregulation of osteoclastic events and osteoblastic events. Tissue turnover is around 3 times increase in fold. In 1959, this was thought of as basically being bony block movement, and we know that that's not correct today. We also know that just elevating a flap alone produces a regional acceleratory phenomena. The problem with that is that it really isn't pervasive enough to move teeth through. In 2001, the Wilco brothers really kind of described the correct physiologic phenomena that occurs with corticotomy surgery and dental alveolar decortication. It's not a bony block movement, but really what it is a coupled demineralization, remineralization phenomena for a defined period of time that allows teeth to move in a less stressed environment or a less mineralized environment. Most recently, Susan Ballou out of Boston University published this paper to really produce the first level of scientific evidence of what happens in corticotomy-assisted orthodontia. And the implications of her study are the following. Essentially, there's a bypass of the lag phase or the rate-limiting step of orthodontic therapy. The coupling mechanism that we talked about earlier, the demineralization, remineralization phenomena, occurs much earlier. There's a reduction in the risk of hyalinization of the periodontal ligament, and there's also a reversible osteopenia that occurs with, in fact, no pathologic loss of bone mass, density, mass, or volume. In fact, there's actually an increase in bone density at the end of the regional acceleratory phenomena. This is essentially what happens. This is a cross-sectional view of the rat model showing mineralized bone in between the roots, and after the injury has occurred, you notice that the periodontal ligament area has expanded greatly, and the mineralization between the tooth roots has essentially, calcium has been depleted, and the mineralization has been there's been a demineralization that has occurred. This is what allows teeth to move more rapidly because there's less mineral environment for them to be moved through. But at 28 days, they show a distinct increase in bone density. So essentially the findings of their study is that there's less calcified spongiosa bone context, actually twofold. There's a greater periodontal ligament surface area. There's an increase in catabolic and anabolic activity, and there's a significant increase in tissue turnover at 3 weeks. So let's look at a case demonstrating surgically facilitated orthodontic therapy in what would be an otherwise surgical case. And I also want to thank Dr. David Forbes, who was the orthodontist involved in this case and helped put these slides together. So this is how Vera presents, and when you look at her soft tissue profile, this is essentially what she looks like. She's a class 3 malocclusion with an alveoloskeletal problem. So the zygomatic malar processes are retruded. The alveolar complexes may be in the right position, but she's a little bit maxillary deficient. And so she presents with not just a skeletal problem, but also a deficiency in dental alveolar bone. This is the class 3 skeletal, and certainly muscle pressure has an effect long-term on the anatomic profile that we will see. She was originally referred to me for recession, but when we step back and take a more craniomandibular approach at her overall case, we notice that she has a posterior crossbite, she has an anterior open bite, and she has a significant discrepancy in the midlines. This is her arch form of both the maxilla and the mandibular arches, and this is the models that Dr. Forbes secured, and you can see the malocclusion, the end-to-end relationship, and really the kind of class 3 profile that she has. This is her cephalometrics demonstrating a maxillary deficiency and a thin labial plate. These are the radiographs that we historically take, which essentially don't really tell you much about this patient other than the fact that they can validate she doesn't have periodontal disease and perhaps she's a Miller class 1 or 2 recession case in which root coverage would be otherwise predictable. But in just taking a myopic view, would we not perhaps maximize the longevity of her dentition over the long term? So here are her problems. She has an anterior and posterior malocclusion. She has gingival recession at 2 teeth, and she has a thin dental alveolar bone phenotype. How we're going to manage her is surgically facilitated orthodontic therapy to increase the dental alveolar bone in both arches and provide root coverage by means of autogenous connective tissue grafting. The imaging that we'll take in a fully seated condylar position using a radiolucent bite registration and a chin cup so that we can get an accurate position of the full field of view that we're going to be evaluating, and it will be supported by a oral and maxillofacial radiologist so that I can sit down with Vera and go over her radiology her imaging findings and her radiology report, creating a value-based, meaningful medical model approach to her care. Here are the cross-sectional views, just like in the Boozer study, looking at MP1 or MP2, very thin facial bone. So if we're going to move her upper arch out, she has very little bone to do that. So these are some of the instrumentation that we will use. This is the maxillary surgery, showing very thin dental alveolar bone, fenestrations and dehiscences throughout. These are the corticotomies. These cannot be chicken scratch. This has to be deep corticotomies in the direction of tooth movement so that we can expose the endosteum, the marrow. This is where the blood vessels are going to come from, and the mesenchymal stem cells to help organize and heal the bone graft that we'll be placing momentarily. Autogenous connective tissue is harvested. You can see the mineralized freeze-dried bone allograft that's placed on the tooth with a layer of bioos or xenograft that will be layered over that. This is alloderm, which will serve as our so-called membrane or our graft stabilizer. And I will also place autogenous connective tissue for root coverage purposes here as well, and not rely exclusively on my acellular dermal matrix. Suturing that is done, as you see on the slide on the right, and then we'll move to the lower arch. And this is what Dave has to work with. There isn't any bone around the teeth. He's handcuffed more or less in terms of what he can do biologically. So what I'm going to do is change the phenotype, and we're going to create injury and explode the regional acceleratory phenomena for not necessarily more rapid tooth movement, but for safer tooth movement and an improvement in long-term biologic health. The corticotomies are done with a 700 or 701 straight carbide burr in a straight handpiece, and injury is key. You can see the depth of the corticotomy, making sure that we're in the marrow, getting those blood vessels out and really producing injury around the teeth. The apical cuts are at least 5 millimeters apical to the tooth roots. You can see some of the perforations that we're doing here when we're near the neurovascular bundle, and the dental alveolar decortication, which we do along the tooth root surfaces where there isn't a fenestration or dehiscence. This is being done with a piezosurgery ultrasonic tip. Oftentimes we'll do them in a dental handpiece with a round diamond burr. These are osteotomes that are being used. This is a 12 o'clock view just to kind of show the scope of the surgery. This is a large surgery. It's being done under the most sterile conditions possible in an oral surgery environment with either IV sedation or an intubated general anesthesia in office with a dental anesthesiologist. The single incision technique for autogenous connective tissue graft harvesting with a single incision and a primary wound closure in the palate. We're going to now re-engineer the dental alveolar bone complex, as you can see here, and increase the outer orthodontic walls using mineralized freeze-dried bone allograft and xenograft. I will stabilize this in the lower arch with a collagen tape or Collatape. This is not a barrier membrane, but rather more of a wound dressing for graft containment and stabilization. And then use suspensory sutures to help suture the connective tissue in place where there were mucogingival deficiencies or the soft tissue was very thin. We will then do blunt dissection. We will release the muscle and try to get coronal repositioning of the flap in a very, very passive environment. We need to be mindful from the very beginning if the patient has mentalis strain, because that may be an impediment for this flap staying in its position, and perhaps this patient may need to have the mentalis muscle paralyzed before surgery occurs, such as with Botox. This is the healing at a few weeks post-op. And you can see the thickness of the dental alveolar bone in the slide to the right. We will now begin to move the teeth under the regional acceleratory phenomena, get the coupling to occur for good anterior protected articulation, a good interincisal angle relationship. You can see the broad arch form that we're creating, perhaps having an impact on anterior tongue posturing because the box is being made larger. And these are the models that were secured and digitized postoperatively, and you can see the changes in the bone volume and the coupling of the anterior and posterior teeth. Again, this was all made possible by Dr. David Forbes. So here she was before, and here she is afterwards. So instead of taking a myopic view and just addressing the mucogingival problem in the recession, we're taking a more global view and addressing the bite, the mucogingival problems, the dental alveolar bone problems, and her occlusion, and hopefully, perhaps, her airway. Could we imagine to get to a point one day where we're not just periodontists engineering dental alveolar bone or saving teeth or covering roots or putting in implants, but we're actually a periodontist I'm actually a periodontist who's having an impact on the airway. Now that's a big picture approach, and that's the view that we're looking at today. So before and after arch forms, in the mandible, and you can see the difference before and after in terms of the dental alveolar bone phenotype. This has also been shown to have an improvement in long-term orthodontic stability. And you can see the difference in the maxillary arch before and after, not just in the dental alveolar bone phenotype, but also in the root coverage results at number 6. And here's the post-treatment cephalometric showing the thick plates, the uprighted mandibular incisor. Essentially, Dave has taken that tooth right out of the bone, gotten a good interincisal angle position, which he really couldn't have done otherwise without the assistance of the regenerative effort through SFOT. These are before and after cone beams that were merged through Materialize. The image that you see on your left is the pre-treatment bone and the pre-treatment tooth position. The image that you see in the middle is the merging of the pre and post cone beam data, looking at the preoperative bone position, but the postoperative tooth position. And you can see that we would have taken those teeth right out of the dental alveolar bone envelope. But what we ended up with on the right side, because of the approach of using surgically facilitated orthodontic therapy, we've gotten a beautiful bone regeneration response and an improvement in the long-term periodontal phenotype of this patient. And in a fully seated condylar position, you can see, looking superiorly, that those teeth would have come right out of the bone envelope. There just wasn't enough bone to move the teeth as there is so much of the time. So we've looked at the human problem or the human condition and the fact that we have very little facial bone. We've classified the dental alveolar bone and skeletal bone phenotypes using cone beam CT scan, and I've given you a paper that can be used in your practice when evaluating these cases. We've also reevaluated our outcome goals, having surgically facilitated orthodontic therapy as a part of our armamentarium from an orthodontic, periodontic, and restorative standpoint. We've talked about the regional acceleratory phenomena, the science behind it. We've discussed and described corticotomy surgery, as well as shown you really a skeletal case that was managed by SFOT because it was essentially a case that was considered to be in the gray zone, treatable by a less invasive surgery. So the structures for treating complex cases: coronal morphology of the tooth, the root position, and the dental alveolar bone. Today we're saying let's flip the script. Let's go ahead and augment the most plastic structure in the body, the dental alveolar bone. Let's put the roots in the right position for facial aesthetics and function, and let's restore the teeth with the most minimally invasive dentistry that we have, biomimetically. So surgically facilitated orthodontic therapy, we do them for 5 reasons: to put the teeth in the right position for facial aesthetics, to transform the phenotype in order to make number 1 happen, because the periodontal phenotype is quite vulnerable and we have very little facial bone natively, to improve the long-term orthodontic stability and reduce the incidence of orthodontic relapse. There's now a 10-year paper out by Don Ferguson and the Wilco brothers showing increased stability using the corticotomy approach compared to conventional orthodontic therapy, to optimize anterior protected articulation parameters, and to consider airway dimensions with non-retractive orthodontics. So anterior protected articulation in a fully seated condylar position instead of camouflage orthodontics, or in certain cases that would otherwise require orthognathic surgery, to couple the anterior teeth and not produce this type of periodontal phenotype, but rather provide a robust dental alveolar bone phenotype for long-term health and stability. I want to thank Dr. David Forbes and Brian Vence for helping me put this presentation together and being my restorative and orthodontic team members in these concepts. And thank you for your attention.